Good day, everyone. We shall begin the APAACI Masterclass entitled Best Practices in Treating Severe Allergy Patients. For our Chinese participants, to listen to the webinar in Chinese, please make sure to check the translation option at the bottom right of the screen, click Interpretation, then select Chinese, and then select the Mute Original option. Good evening, everyone. Especially to our friends in the Asia Pacific, good morning and good evening to our colleagues around the globe. Let me introduce myself. I am Dr. Felicia Racquel Salvador-Tayag, and I am the current president of the Philippine Society of Allergy, Asthma, and Immunology. I am honored to be your moderator for today's masterclass. In behalf of Professor B. Pawangkar, Executive Director of APAACI, and Professor Zhu Yao Wong, President of the APAACI, I welcome all of you to the APAACI Masterclass entitled Best Practices in Treating Severe Allergy Patients. Today, we are privileged to have three distinguished speakers from different continents, all experts in the field of allergy and immunology. Our lecturers will discuss how to best manage severe allergies such as anaphylaxis, pollen allergy, allergic rhinitis, and its comorbidities. I will be introducing each speaker before their lecture, and we will have an open forum after all three lectures are finished. I'm sure that we will all have lots of learning today, which will be very useful in our clinical practice. Before I introduce our first speaker, let me read to you the webinar's house rules. This webinar will be recorded and will be uploaded on APAACI TV at www.apaaci.org and all other APAACI learning and online platforms. All the participants will be muted by the organizers upon entry. The Q&A feature provides an opportunity for attendees to answer questions for the presenters, and at the end of the webinar, we will get the speakers to respond. Due to time restrictions, any questions left unanswered will be uploaded onto www.apaaci.org with the answers from each speaker. So let us begin. Our first lecture is entitled Best Practices in Treating Patients with Severe Allergies, Anaphylaxis. Our speaker is the Director of Allergy Medical in Brisbane. He is a professor in the Menzies Research Institute, National Center for Neuroimmunology and Emerging Disease. He is the chair in Allergy, OPRI in Singapore. He is a member of the European and Australian Allergy and Rhinology Society, member of the American Academy of Asthma, Allergy, and Clinical Immunology, and the World Allergy Organization, and a faculty member of Euphoria. Ladies and gentlemen, let us welcome our first speaker, Professor Pete Smith.
Thanks very much, Felicia. I hope I'm live now and you can grab my presentation. I think I need to share my screen, which will bring that there. And welcome to other panelists as well as everybody around Southeast Asia and wherever else in the world they're choosing to join us. What my remit has been is to talk about anaphylaxis, what it is, and particularly tips for practice, and update people with where we are in 2023. And in doing so, many of us will recognize anaphylaxis. I'll talk about that as well. And what more can we do? Let's try and think a little bit outside the box. Let's be the best doctors we can be, but let's try and push things a little bit harder. What can we do better? What are we missing? What are some of the easy goals that we sometimes may overlook? So parts of allergy prevention, education and communication are critical. Getting people's allergic health burden is important, and that does appear to contribute to severity of anaphylaxis. I think as doctors, we do focus on the allergic problem at hand, and trying to think about general health also improves outcomes in allergic events, but also people's general life. And I think we have a bigger role to play in that. And some of my colleagues are going beyond global health and beyond personal health and thinking about global health as well, which does impact. The recognition of reactions is very important, as is early effective treatment. I'll discuss like using an auto-injector akin to using a parachute. It's great to have one. It's even better to use one when, and use one early. And we're now looking with food allergy. We know definitely with bee and wasp, there's major benefits of decreasing risk of anaphylaxis, say by figures of about 80%. But we're now doing food allergy desensitization. And there's two types of goals that we have. There are many different types of doing food allergy desensitization, but goals of getting people to a level where they're safe for contact reactions, or actually levels where they're actually safe to consume the product. So with prevention, assessment and education, it's critical that we identify the allergens, and most of us will be using skin prick test. It's important to identify the difference between sensitization, that's the presence of antibodies, whereas allergy is an allergic reaction to that sensitization. If you've had a reaction to one, part of it, the value of seeing an expert is they'll know if you react to cashew, there's a pretty good chance you're going to react to pistachio. We crunched out our numbers of 500 patients and found 76% of patients who had cashew allergy reacted to pistachio. 98% of people who'd reacted to pistachio reacted to cashew. So there's twinning of several nut allergens. Walnut and pecan, macadamia, hazelnut have about a 50-odd%. Peanut, probably about 12 to 20% of people who are peanut allergic react to lupin. There's other seeds that peanut will react to, being it groundnut. There's various lentils which are consumed in Asian countries. We're even seeing peanut cross-react with a seed storage protein on oranges and mandarins, but we also see that with cashew allergy as well. Skin prick tests do give us values in somebody who has had an allergic reaction, and a predictive value. And it is important to assess and reassess. I certainly will discuss patients, their age-related risks and responsibilities. And at 5 years of age, my goal of the patient is to ask them what they're allergic to and be able to have them state their allergens, so they can communicate that. So they can communicate not taking food from people other than their primary caregivers. At 7 or 8, that's the age people have an awareness of their mortality. That's the time that I make sure they know how to use their auto injectors. At 10, it's their job to carry around the auto injector. And because that's an expectation. If I only have one rule for my patients, and I'll tell them that with food allergy, if they even have their auto injector. At 12, I'll ask them to have start doing the food allergy ordering, because sometimes the teenagers are a bit shy. So I give them that opportunity to start taking control of saying, excuse me, I have severe peanut and cashew, pecan allergy. I'm also severely allergic to shellfish. Is there anything on the menu that I need to be aware of? And can you please let the chef know? This is not to be defensive, but to be proactive and have that opportunity to practice while the parents are about. I also ask them to, at 14, I'll talk about kissing reactions. Nut can stay on the saliva for 1 to 2 hours, or on the teeth up to 2 days. There's also issues, and 16 years of age, I'll start doing a discussion about alcohol. Alcohol has varying ages of access, 18 to 21 across the Asian region, but 16 may be the last time you're seeing them as a pediatric patient. So having that discussion about it, recognizing, reducing risk, irritating the stomach, you may not recognize the allergen, you may be late to treat. So an importance of being in control of yourself and being able to recognize reactions and respond to them. Also, blood sugar drops when you drink, so you actually get a little bit hungry and you may not make the best choices there as well. So having a think about what you're going to have if you do have a couple of drinks that is low risk. Communication, when we're dealing across languages, the sentence, does this food have peanut, compared to does this food not have peanut, sound very, very similar. And culturally, a lot of us, particularly in the sales circumstance, are trying to be agreeable. So we do find confusion. So language cards are actually quite useful. I had a patient who survived for 10 years in Vietnam with English as their primary language, and they wrote severe peanut allergy, small amounts can kill, because some people may not understand anaphylaxis. They might think allergies is hay fever. So she had that translated. There was no doubt about what the nuts what would happen if there were contamination, and she found she was looked after perfectly by just communicating the right way. I'm not trying to give that message to my patients that small amounts can kill. We want patients to be in control of their allergies, not allergies to control them. I'd also like to stress that reactions are 4 times more likely to occur when traveling because you don't have your same safe sources, but communication is critical. This is a paper, a combination of 2 risk papers, one done by Summers about 15 years ago, and looked at the risk with nut allergies and the odds ratios for severe symptoms with anaphylaxis, so-called stack. If you're actually unwell, your risk of severe hypotension with severe eczema was about 3 times more likely with anaphylaxis. If you had bad hay fever, fire on top of fire. So upper airways obstruction was 3.8 times more likely if the patient had severe rhinitis. So assessing a patient with anaphylaxis is more than just checking their skin prick test, getting their auto-injectors up to date, and writing out a management plan. Severe asthma was 6.8 times more likely if there was a history of severe bronchospasm was 6.8 times more likely. And if you even had mild asthma, bronchospasm was 2.7 times more likely. If you've got hereditary alpha tryptase, i.e. your tryptase is above 11.5 micrograms per litre, but we even go looking for it with levels above 8, you're 3.5 times more likely to have severe anaphylaxis. And this is a relatively new factor that was only published a couple of years ago by Jonathan Lyons and the group out of NIH. And what the hereditary alpha tryptosemia is, it's present in approximately 5% of the population. So you're 3.5 times more likely to have a severe idiopathic anaphylaxis. If you've got mastocytosis, you're more likely to have severe anaphylaxis. If you've got hymenectic venom, anaphylaxis twice as likely. Now, alpha tryptase is a protease that's secreted out of the mast cell. It's just oozed out all the time, whereas the beta tryptase is excreted in with endosomes that get released to the outside, and the alpha and beta will form functional heterodimers. So you'll see a quadrimer, and that quadrimer goes and cleaves part 2 on endothelium and causes these massive endothelial leak. So if you've got more alpha about when some beta gets released, you're more likely to have severe hypotension and dramatic anaphylaxis. So this is something just to think about, and checking your tryptase. If your tryptase is elevated during anaphylaxis, great, but get a baseline. If it doesn't go down, you might be looking for a hat. General health, I did give a prelude into this. We know that sleep is important, and there are circadian effects of histamine and steroids. Our histamine levels are lowest in the morning and highest at about 2 a.m. in the morning. And steroids, we know, are highest at about 6 a.m. and lowest at about 2 a.m. So we actually have this witching hour where we're actually more likely to have more severe reactions. We know that sleep deprivation, Shelley Dwell's paper in late 2019 showed that if you had sleep deprivation, the threshold for peanut allergy was almost half the dose. We know that we're staying indoors a lot, and both magnesium or vitamin D will help stabilize mast cells. It's not the cause of anaphylaxis, but mast cell lability is greater with low vitamin D. Magnesium is depleted from our soils, and many of us don't have enough magnesium. Also, if you're using beta agonists a lot, magnesium depletes quite a bit. So somebody who's had repeated doses of adrenaline or sitting on Ventolin puffers, we know magnesium gets depleted. And in those cases, intravenous magnesium seems to be one of those rescue factors for severe asthma. Exercise, it's great to be fit. So you've got resilience and the ability to cope with stresses. But if you've got a food, there is food-dependent exercise-induced anaphylaxis. And like sleep, Shelley Dwell's paper showed that if you exercise to 80% of VO2 max, the dose required to induce an anaphylaxis was reduced by about 45%. It's also important to have great mental health. We know that stress can cause urticaria. There's very little on stress and anaphylaxis, but we know that if we're stressed, we make corticotrophin releasing factor, and that has binding points on mast cells. Acetylcholine has binding on mast cells. And there were lovely studies done by Alia Crum, who's now in Stanford. She actually showed that with histamine skin prick tests, you could tell patients you're going to get a bigger skin prick test or a smaller skin prick test with exactly the same cream. And within 6 minutes, it was larger if patients were told that it was going to be a larger skin prick test with the cream, exactly the same cream. So we actually have a mindset of intent that can influence allergic reactions. This is Shelley Dwell's paper. Again, here we show the baseline. They actually had the patients come in placebo with no intervention, because people do get learning of responses. And with sleep deprivation, they're only allowed 2 hours sleep, and with exercise, the amount of dose that was required was reduced significantly, almost, as I've mentioned, going to a figure of almost half the dose is required to induce anaphylaxis with both exercise or sleep deprivation. The Nobel Prize back in 2016 was clock genes. I'm not going to expect to know all those. In fact, I don't know all of these myself, but light does affect these complex set of genes, which does affect factors like c-KIT, the high affinity IgE receptor, tryptase production, and mast cells certainly are more active in the evening and early hours of the morning. So if you're going to do food allergy challenges, they're better done in the morning. If you're going to do immunotherapy, better do those patients in the morning. Going back to these are the gods of and the leaders in food anaphylaxis. Younginger back in the 80s, and Hugh Sampson and Richard Pumphrey really defined the pathways on time to treat and risk of death. And with patients with food anaphylaxis with fatalities, all fatal reactions, we find that patients who delay treatment tend to have worse outcomes. We need to treat people within the first 10 to 15 minutes. If they've got severe symptoms, earlier treatment is a better outcome. In Richard Pumphrey's data, only 20% of patients had been given adrenaline before they arrested. In our data that's come out of Australia, in fact, not my personal data, but data from Ray Mullins, he reported that only 40% have seen an allergy specialist. Less than 10% actually had adrenaline available to those patients who actually had fatal reactions. This is a paper on risk factors in severe anaphylaxis. So these factors contribute to this severity. So if food's concealed in chocolates or fatty matrices, they may not recognize the food and may not get that early tingling. Teenagers and adults have a tendency to not carry their auto-injectors. There's disease denial. Some of them get drunk, which affects recognition of symptoms, recognition of risks, and timely treatment. And later absent treatment also is affected by appropriate training, and sometimes language comprehension or intellectual disability as well. Allergic disease load are cofactors, and there are a range of metabolic factors, including exercise, illness, alcohol, medications, and there are some enzymatic defects that make people more likely, and I'd put sleep deprivation in this as well. And we created this hypothetical model, Jonathan Horahan, Phil Leven, and myself, where this person up the top, same at the bottom, same dose of allergen, same IgE response, but this allergic disease burden was heavier in this patient. And metabolic factors, they hadn't been exercising. This person was a bit sleep deprived and had been recently unwell. They'd been taking an aspirin or Nurofen, and this person hadn't. And this person treated early, this person hadn't had appropriate training and treated late. So these cofactors can be the difference between a severe and mild reaction. So I've said it's important to recognize anaphylaxis. And what is anaphylaxis? It's a severe life-threatening generalized or systemic hypersensitivity reaction. And there's IgE and non-IgE subclasses. They involve brain, cardiovascular symptoms, eyes, airways, essentially an allergic reaction that compromises either circulation or breathing. APAACI defines it as acute onset of an illness with hives and swelling with respiratory or cardiovascular involvement or persistent GI symptoms or. They also can define as acute onset hypertension or bronchospasm as well, if the atypical skin features are not present. And sometimes you can drop your blood pressure so much you may not get a rash. And there will be patients who don't have those full features, but if you suspect that in a patient, best thing is to probably go and treat. And this is a caveat from Phil Lieberman, ex-president of the American Academy of Allergy and Immunology. Now, anaphylaxis is indicated by difficulty breathing, swelling of the tongue, tightness of the throat, difficulty talking, dizziness or collapse, being pale and floppy, having abdominal pain. Treating anaphylaxis, these are ASCII comments. Remove the allergen. If there's a sting, flick it out. If it's a bee sting, don't squeeze it. You squeeze the venom sac. Lay the person flat. It's easy to get blood to the heart and the brain. Immediate care, give adrenaline. If in doubt, give adrenaline. This is a statement from the Director General of Health in the United Kingdom in 1993, and I hope it resonates on many anaphylaxis plans around the world. Give oxygen as available, call the ambulance, then call the family. Give adrenaline if there's no response within 5 minutes. I like to rub the site because you're asking for lymphatics and venous drainage. That's fallen off many management plans because there's not randomized controlled trials, but I think logic is quite useful as well. Pardon me, if somebody has adrenaline, they should be watched for at least 4 hours. You're far more likely to need a second pen if the first pen takes more than 15 minutes to give, or if the patient has asthma, particularly if the asthma is poorly controlled. And if the patient is unresponsive, give CPR. Always give adrenaline first, then the asthma reliever. In somebody with known asthma and allergic foods, if the patient has sudden difficulty breathing or collapse. Most reactions are within minutes, but anaphylaxis can occur up 1 to 2 hours of eating a food, but over 90% occur within 30 minutes. It can be delayed for several hours with things like mammalian meat allergies, and anaphylaxis to things in injected medications almost occur on the ends of the needles. And anaphylaxis to oral medications can occur, but with less speed than injected medications. Adrenaline reduces airway edema, increases bronchodilation, constricts the blood vessels, and increases the strength of the cardiac output. And we usually give 0.01 milligrams per kilogram up to 0.5 milligrams without, and the sweet spot looks to be about 13 millimeters. I know if you put it going in 25 millimeters, it takes longer to get a peak serum level. So depth and the dose is important. This is an algorithm I put together with Jonathan Horahan. So for mild reactions, antihistamines, you might use H1 and H2 antihistamines. Now we've got some very good ones. For moderate are H2 and H4 antihistamine. Also infused with spike COVID protein apparently as well. But if the angioedema is severe, I'd be giving adrenaline as well. The patient's going to feel comfortable. Antihistamines, steroids, glucagon. If you've given 2 EpiPens, think about glucagon as well, and IV fluids. Lift the legs up, that returns about half a litre to 1 litre of fluid to the body. Management plans are important so patients have a roadmap of what to do in the future. And again, give the auto-injector early. We've got a couple of auto-injectors on the market and you may have different devices in your countries. Media bracelets are great. Get it right. This patient actually had wasp allergy. This patient had a tattooist who couldn't spell, so show them how to spell anaphylaxis as well. We have in ASCII, and again, these are freely available through allergy.org.au. This is an event record for allergic reactions, so we can gather more information if we have an event where people can't really determine what was the cause. So this might be something regionally the Asia Pacific Association choose to have a look at creating their own document. Referring to an allergist is important, but it doesn't happen that frequently. We did a paper on this and showed that the average referral rate was 33%. It doesn't take much work, but we know that it affects mortality if somebody has subsequent reactions, and making sure they get an auto-injector. 44% is prescription. Now, even if they get a script, this data has come out of Denmark, where the auto-injectors are free from the hospital pharmacy. But how many people actually pick them up? The 18 to 35-year-old, over half don't even bother to pick up their auto-injector after they've had a life-threatening episode and deem that this is important. Many patients don't bother carrying their auto-injector and don't know how to use it. Between a quarter and a bit over 40% recall how to use it when at follow-up. So it's an important thing to show them when you see them again. And switching between brands can also be very difficult. The brands are very different in their mechanism of use. Now, desensitization is a hot thing on the map, and it must be offered if somebody's had bee and wasp. It increases their decreases the rate of risk of anaphylaxis by over 80%. They still have a risk of anaphylaxis, but their mental health improves and quality of life improves because they're actually doing something about their health. And there's an emerging role of oral immunotherapy in food allergy. I had the pleasure of being involved in this working party, which meant many hours of being up at 2 o'clock in the morning for European working parties. But the data is out of looking at 140 papers that for selected people with peanut allergy, there is now evidence of high certainty for selected patients of doing oral immunotherapy in children and moderate levels of certainty for patients with persistent egg and cow's milk allergy for doing desensitization. So that's a recent evidence-based support of this changing practice, which does reduce risk. And the patients that I've had through are so overjoyed to be having this. And my goal is to bring them to eating it 2 or 3 times a week, which brings down their risk of anaphylaxis. So my goals for tonight was, what are the modifiable risk factors? Talking about prevention, education, and communication, looking at allergic health as well as general health, recognizing reactions, stressing the importance of early effective treatment, and just bringing in desensitization if appropriate. With the desensitization, I'll also put a caveat: there have been 2 milk anaphylaxis deaths. So both of them were in young children who had active asthma at the time of desensitization. So the patients do need to be well and need to be done in a very supervised situation, and make sure they're not wheezy and not allergically unwell in any way when you're doing that. So thank you very much.
Thank you very much, Professor Smith. It's really the education and communication that's very important in treating anaphylaxis patients. And of course, the timing of giving your adrenaline is the key in the management of anaphylaxis. We now go to our second lecture. Our lecturer is a consultant allergist at the Royal Brompton Hospital in London. He is an honorary senior clinical lecturer at the Imperial College London. And Dr. Scadding's clinical interests include food and drug allergy, rhinitis, rhinosinusitis, and he has given talks and lectures in the UK and Europe, including Master in Science in Immunology and Allergy courses. Friends, let us welcome Professor Guy Scadding.
Many thanks for inviting me to speak and participate in this APAAACI masterclass. It's a great pleasure to be speaking to people halfway across the world. So I'm going to talk to you about best practice in managing patients with pollen allergy. So let me just load up my slides and we'll get started. Right, there we are. Okay, so best practice in management of patients with pollen allergy. These are the general patterns of pollens in the UK. So obviously this is where I work, so this is the bit I know most about. But clearly things are very different where you are. You'll see at the top, the taxa there is tree pollens. So tree pollens is a major issue, and it's probably getting worse year on year in the UK. We use silver birch pollen as the archetypal tree pollen allergen in the UK and in much of Northern Europe. That's partly because it's a major problem itself, but partly because that's where a lot of the research is done, and because it's very, very highly cross-reactive with many of the other tree pollen species. That said, still the major problem, the major cause of seasonal pollen allergy in the UK remains grass pollen. And you can see that below the trees, the season for grass pollen is slightly later. So trees we classically see as being spring, grasses summer. And that still remains the major problem. Below that, you'll see a mix of weed pollens and other pollens, and those can be an issue for patients, but they tend to be slightly more minor than trees and grasses. So I'm aware that the APAACI region is absolutely huge, a lot bigger than the UK, a lot bigger than Europe. So and you encompass tropical, subtropical and temperate regions. So you will have, many of you will have very similar pollens to the ones I've described, but others will have different pollens. So you'll have tropical grasses like Bermuda grass. You'll have plants that we don't really have, like Japanese hops, sawtooth oak. I know that in certain places like Japan, there are very specific problems with Japanese cedar. Some of you will have more problems with ragweed as they do in the US, which we don't really have much of in the UK, but other parts of Europe they do. And then there are other grass-like species like sedge that can also be problematic for you that we don't tend to have as a major problem here for us. So I've tried to give you some relevance to your own practice there. In the UK, the grass pollen season peaks at the height of summer, which tends to be when children are doing their examinations. And you can see that if you have troublesome grass pollen hay fever, it's just at the wrong time when you're sitting your GCSEs. These are national exams sat at 16, and then the other national exams also tend to be set around the same times of year. And people with bad pollen allergy can really suffer at these times, and it can affect their exam performance. Ditto, as you get older at university and to adulthood, it can affect academic performance and it can affect your working life. So it's a major issue. In terms of managing allergic rhinitis or managing pollen allergy, the steps we're going to discuss today are these. So diagnosis, allergen avoidance where possible, pharmacotherapy, correct adherence and use of pharmacotherapy, and then a bit about allergen immunotherapy. So always worth thinking about the differential diagnosis of rhinitis. With pollen allergy, it's usually fairly obvious. So patients are having typical allergic symptoms at the same time of year each year, and you can usually easily confirm that on a skin prick or a specific IgE test. So normally the differential diagnosis is not difficult here. On the other hand, it's always worth considering whether patients may have additional problems. So occasionally we will see patients who, for example, have chronic rhinosinusitis as well as their pollen allergy, in which case you really need to treat both, and you need to get on top of that chronic rhinosinusitis, because if that is out of control, by the time the summer or spring comes round, you'll have very little chance in controlling their allergic disease. And then for things like structural problems, septal deviation may make delivery of medications difficult. So these things should be considered as well if they're a problem as well as the pollen allergy. Allergen avoidance for outdoor allergens is extremely difficult. You can change your lifestyle and that can help to some extent. These are things that have been suggested. So you could simply leave the country. If you go far enough away, typically if you go to or further away from the equator, you can affect what you're allergic to. You can get away from it, but this is not necessarily very practical and certainly not very cheap. In terms of pollens, you could avoid the outdoors, you could avoid grassy areas, you could avoid meadowland or trees, but pollens are very small, they get spread all over the place, so that's very difficult. You can avoid going outside when pollen levels are at their very highest, so you can look at pollen prediction calendars, which are typically given with the weather forecast. You can also stay in the late afternoon, early evening when pollen levels tend to be at their highest at ground level. Pollens tend to rise up higher during the day when it's very hot in the middle of the day and then fall again. And it's that evening time that can be the worst. You can fit a pollen filter to your car. You can keep windows in your car shut. You could put Vaseline or some sort of barrier cream up your nose. When you get home, when you've been outside during the day, you can wash your hair, have a good shower to wash all the pollen off. Does any of this really work? There's no good trial evidence to suggest it does. It's all pretty anecdotal. But there are things that we can recommend to people to see if that can help. An example of a neat little study that shows that allergen avoidance can have an effect is this study, which looked at using nasal air filters. This study was nicely done because it involved having people wear these little nasal speculae with either active filters or placebo filters. So the patient didn't know which one they were getting. And you can see from the graph here, if you shift to the left of baseline, that's an improvement. A shift to the right is worsening. And you can see from baseline, people wearing the active filters tended to do better than people wearing the placebo filters for a number of factors. So all this is doing is preventing entrance of pollen into the nasal mucosa, and that's clearly having a benefit. I should say that in 15 years doing this job, I think I've only met one person wearing anything like this. So they're not something that's yet been taken on. So I don't hold out a great deal of hope for it on a larger scale basis. What about pharmacotherapy? Because this is the mainstay of treatment. It's very difficult to get people to completely change their lifestyle for 2 or 3 months at a time. So this is the British Society of Allergy and Clinical Immunology guideline for managing allergic rhinitis. And you can see at the top of the screen there that as well as trying allergen avoidance and simple saline washes to the nose, the standard treatment for anyone with moderate to severe disease is an intranasal corticosteroid. You can also try antihistamines as first line, but that should really only be for mild disease because they're significantly less effective. If you are going to try an antihistamine, you should be aware they're only mildly effective. We often use them in addition to intranasal steroids, but actually the evidence that they have any added benefit isn't there. I would say please avoid sedating first generation drugs like chlorpheniramine or chlorphenamine because they have serious side effects. And we tend to use cetirizine a lot. A lot of people get prescribed in the UK fexofenadine. There's not actually any evidence that fexofenadine is any better than cetirizine. I'd say they're pretty much much of a muchness, and there's probably not much difference between any of the antihistamines in terms of efficacy. It's been clear for a very long time that intranasal steroids are more effective than oral antihistamines. So this data is very old now, but you can see of all the studies they looked at, only one suggested antihistamines may be more effective. The others all very clearly favored intranasal corticosteroids. So I think this is something we would generally accept. Intranasal steroids are better than oral antihistamines. Intranasal steroids also have the benefit of helping with eye symptoms. This is a study of fluticasone furoate, so one of the newer intranasal corticosteroid drugs. And on the left-hand side, you can see the effect compared to placebo on nasal symptoms. And on the right-hand side, you can see the effect compared to placebo on eye symptoms. So spraying the intranasal steroid in the nose does have a benefit for eye symptoms. So that's something that's always worth bearing in mind and explaining to your patients. Even when their nasal symptoms are relatively mild, it's worth doing if they have troublesome eye symptoms as well. So another benefit of intranasal steroids. For patients with very troublesome eye symptoms, as well as using the nasal steroid, we tend to use sodium chromoglycate or nodocromyl sodium drops as first line. These are effective, but have to be applied 4 or 5 times a day. So that's quite a burden on the patient. If they're not responding to those, I would then tend to add in addition, an antihistamine stroke mast cell stabilizing drop. So one of azolastine, olopatadine, or ketotifen is what I would normally use. They tend to be twice a day dosing, so I'd use those alongside the frequent sodium chromoglycate. As I said, ensure they're taking an intranasal steroid. If they're still having very troublesome eye symptoms or any worrying signs, chronic red eyes, painful eyes, swelling, I would generally then ask for an ophthalmology opinion as well. The next step in treating them would be a topical corticosteroid drop, and that tends to involve closer ophthalmological monitoring. So if we agree that nasal steroids are the basic mainstay of treatment, the question arises as to which nasal steroid is best to use. And there's not really a simple answer to that. There are a number of them out there. So FP, fluticasone propionate, mometasone, furoate, budesonide, triamcinolone, beclomethasone, flunizolide, and fluticasone furoate are all the drugs that are available on the UK market. They all work well. The only real clear differences in them are, for example, FP, mometasone, and FF tend to have a lower systemic bioavailability, probably particularly FP and mometasone. So you could argue from a safety perspective, those are better drugs to go for. Most of them are only once daily dosing, but beconate or beclomethasone and Cintaris, flunizolide need to be given twice daily, so perhaps that's a slight disadvantage. We've seen that the best data for eye symptoms comes from fluticasone furoate, but my suspicion is they all help eye symptoms. Most of them have some sort of odor which some patients don't like. For us, triamcinolone or Nasacort doesn't have that odor, so maybe better tolerated. Many of them have the preservative benzalkonium chloride, which occasionally causes nasal irritation in some patients. For us, budesonide and triamcinolone don't have that, so those are things that they can consider. And then most of the devices are similar, being application devices that you press down like this. We have Avamis that you press on the side and has a slightly finer spray, and some people prefer that, so that's something to consider as well. If your patient is taking their intranasal steroid correctly and regularly and they're not getting any better, the next step is a combination intranasal steroid and intranasal antihistamine. So about a decade ago, there were plenty of studies showing that the combination of fluticasone and azolastine was superior to either treatment alone. There was a study looking at the combination of intranasal steroid and oxymetazoline, so a decongestant, and that showed improvement compared to single drug alone. There hasn't been a further movement in terms of combinations with decongestants, and further trials are needed. There is a concern about rhinitis medicamentosa, but the INS azolastine has proved to be a very successful treatment. You're probably aware of this drug as Dymista. So these are the meta-analyses of the studies at the time of licensing, and you can see that the combination drug on the left in the histogram there shows significant improvement compared to either drug alone. And on the right hand side, you can see this shows how long it takes patients to achieve a 50% improvement in their symptoms, which is a really big improvement. And you can see that with the combination drug, more patients are getting there and getting there quicker. So definitely an improvement over intranasal steroid alone, or an improvement over intranasal antihistamine alone. More recently, there has been another combination drug on the market. This is a combination of olopatadine, so that's the antihistamine, and mometasone, the intranasal steroid. This is a study done on a large number of patients, just over 14 days, comparing the combination drug to the two individual drugs and placebo. And you can see that very early on, you get an improvement in the combination drug compared to either drug alone, and more so compared to placebo. So again, the combination gives added benefit. So there are two drugs now available for us to prescribe. Adherence and correct use of medication is crucial. We see so many people where we recommend particularly nasal steroids, and we find out the patient doesn't like using them, or isn't using them regularly, or isn't applying it correctly. So this is something always to check at each stage. Are they using it correctly? Are they using it regularly? Are they using the right dose? The technique for a nasal spray, I'm sure you're all very aware of this, but head slightly forward. Depending on the drug, it's either 1 or 2 sprays to each nostril, and spray back and ever so slightly laterally, so away from the nasal septum. Tell the patient not to sniff too hard, otherwise they'll simply swallow it all. They don't need to be covering a nostril, breathing in deeply. And they will feel the fluid in their nasal mucosa. They just need to get used to that. When people have very, very inflamed allergic noses, spraying anything in the nose can cause a bit of irritation. So you have to sort of explain to your patients that it may take a few days for things to settle down. And then we tend to ask patients, how long does the bottle last? So most of these drugs are designed for the bottle to last 4 weeks. So if the patient has troublesome hay fever between April and August, and they only pick up 1 prescription, they're clearly not using it very regularly. So where to next? If you've done all that and the patient is still suffering? Well, there are sort of individual things we can try. If the patient has a lot of watery rhinorrhea, we will sometimes add Rhinotec or ipratropium bromide. We might try adding a leukotriene receptor antagonist if they have asthma and a lot of postnasal discharge. And then for patients with a lot of nasal blockage, a brief course of an intranasal decongestion, ideally less than a week, can be done at peak pollen season. Also think about whether there are other pathologies going on, as we discussed previously, whether there are structural problems, infection, chronic rhinosinusitis. And then we will sometimes, at peak pollen season, give people a brief course of oral corticosteroids in addition to their topical treatment, if that's necessary. And if all that fails, then we're thinking about immunotherapy. So some of the things that I try and do with the patients I see, I try to get the patient to begin treatment before the symptoms start, or at least well before peak season. So sometimes people will say, well, I just had a bit of symptoms, so I'm just taking the odd antihistamine. And I think, well, get started on the nasal treatment, use it regularly, because by the time the pollen levels are high, you'll have that advantage. Don't forget nasal saline washes. They can be very useful, particularly at the end of the day. Ensure regular use and collection of prescriptions. As I said, avoid peak pollen times, such as the evenings. patients with hay fever who develop wheezing, coughing, tight chest, it's almost certainly seasonal asthma. So I would simply treat them for that rather than necessarily waiting to undertake any test. At least start treatment for that. It's very likely they will be able to stop treatment as soon as the pollen season finishes. If standard treatment is failing, I sometimes give people a potent intranasal corticosteroid for a couple of weeks. So this is usually either betamethasone or vistamethasone. These are steroids that I tend to use more in chronic rhinosinusitis, but for a couple of weeks when the pollen season is really high, if they're struggling with standard treatments, that can be helpful. If that fails, oral prednisolone, 20 to 30 milligrams a day for up to 7 days at peak pollen season is sometimes needed. I would do that. I would not do depot corticosteroid injections. Allergen immunotherapy. So this is what we tend to reserve for patients who have tried everything else and are still really suffering. And you can see in the UK guideline, immunotherapy comes right at the bottom of the whole flow chart. This is partly because it's completely reasonable to try everything else first, but it's also, I think, partly a financial concern and partly about access. We have relatively few allergy clinics, and there are a huge number of patients with hay fever. Probably a quarter of the country have hay fever, and there's very, very limited access to this sort of treatment. As I'm sure you're aware, allergen immunotherapy is the use of repeated administration of allergen extracts, so purified allergen derivatives, occasionally in altered form, what are called allergoids, given to a patient who's known to be allergic to that substance to try to induce clinical and immunological tolerance when they're subsequently exposed. And that's done either subcutaneously or sublingually. There are other routes being investigated, but these are the mainstays of treatment. This is an example of studies of grass pollen immunotherapy, just looking at the treatment effect. So the two studies on the left in the yellow were two large sublingual studies of grass pollen immunotherapy. The study on the right, one large subcutaneous study. And you can see actually the outcomes look very, very similar. And what you're seeing is the effect versus placebo. So you're seeing a sort of at least 30% reduction in symptoms and at least 40% reduction, maybe even more, in medication use versus placebo. And the really key thing is that this is versus placebo. For allergen immunotherapy studies, the placebo effect is really big. The placebo effect is 30, 40, 50%. So if you actually compare to baseline, these patients are doing a lot better. The other thing about allergen immunotherapy, again, you're probably very well aware of this, is that it has a disease modification potential. So this is a study of grass pollen that looked at 3 years of treatment versus placebo, and then a further 2 years blinded of follow-up observation. And you can see that in those 2 further years, blinded, still randomized, you can see that patients on active treatment still remain better compared to placebo-treated patients. And again, these are all figures versus placebo rather than versus baseline. So actual improvement is probably greater than that. Tree pollen sublingual immunotherapy, there's a very large study in Europe just a few years ago, over 600 patients at sites throughout Europe using a silver birch pollen extract. And as I said before, birch pollen extracts are very similar to major allergen extracts from other trees. And in vitro, you can show that these extracts inhibit human IgE binding to alder pollen, hazel pollen, and oak pollen allergen extracts. So in this study, it was done over a single spring pollen season in Europe, and treatment was started at least 4 months prior to the start of the tree pollen season. Just go on to the next page. There we go. And these are the efficacy outcomes. On the left-hand side, you've got the birch pollen season. So they're concentrating just in the weeks of the major birch pollen season. And you can see on the combined score, which is symptom plus medications, the symptom score and the medication score, there's a significant improvement versus placebo. And again, very similar to grass pollen, you're looking at somewhere between 30 and 50% improvement. If you then look on the right-hand side and you look at the entire tree pollen season, so including hazel, alder, and birch, the effect size is just pretty much just as good. So you're having a good effect throughout most of the tree pollen season. This doesn't include every single tree species we have, so imported tree species are sufficiently different that you won't cover them, but it covers most of the things that are relevant to our patients. And the long-term efficacy of sublingual tablet pollen immunotherapy has now been demonstrated in a number of different studies. On the left-hand side, these two studies are grass studies, but moving on to the right-hand side, you can see that this has also been demonstrated for Japanese cedar pollen. So again, very similar figures with this continued benefit even after stopping treatment. And it's also been demonstrated for grass pollen in children on the right-hand side here. So for adults and children, this seems to be an effective disease-modifying treatment. So how do we select patients for immunotherapy? Well, you've seen that we tend to select patients who have failed to respond to maximum therapy. We take patients whose primary problem is rhinoconjunctivitis. They can have associated asthma, that's fine. The asthma has to be reasonably controlled, it can't be severe. They have to have symptoms on exposure to the relevant allergen, and you have to have demonstrated IgE sensitization. They have to have had an inadequate response to anti-allergic drugs or unacceptable drug side effects. For example, some patients have very problematic epistaxis, nose bleeding, and just cannot tolerate intranasal corticosteroids. They would be applicable for immunotherapy despite not taking those drugs regularly. Polysensitization is not a contraindication. I'll come on to explain that more. Moderate to severe asthma is, uncontrolled asthma is, autoimmunity, immunodeficiency, malignancy. Patients who are pregnant, we would not start on treatment, but we would continue treatment if they were doing well and everything, we're not having any major problems. It's important that patients understand how the treatment is working, and they understand the need to take it regularly in order to get the best benefit. And as I said on the left, I said polysensitization, not a contraindication. Polyallergy, so people who are actively allergic to multiple different things. So for example, if you've got bad hay fever, but you're also cat and dust mite allergic, you live with a cat, we're less keen on treating these patients with, say, pollen immunotherapy because you're less likely to get an overall benefit. That doesn't mean we wouldn't ever consider it, but those are just factors to think about. Which allergens? So efficacy has been demonstrated in large trials for grass, birch, dust mite, cat, ragweed, and Japanese cedar, which I haven't mentioned here, but I showed you on the previous slide, as well as for venom immunotherapy, but that's separate. Immunotherapy is almost certainly given for other things as well. Doesn't mean it doesn't work, but it just means the studies aren't there, and that tends to be an issue in terms of funding and drug authorization. What route of treatment to go for, sublingual or subcutaneous? And to some extent, this is something that is important to discuss with the patient, but also just depends on availability. In recent times, we've moved more towards sublingual treatment. That's in part related to the fact that a number of vaccines have now got a UK license, the sublingual vaccines, so we don't have to use these on a sort of imported named patient basis anymore. In terms of the overall systematic reviews, looking at numerous studies for both SLIT and SCIT, there's not really anything to choose between them. They both work. Safety is a consideration. I'm sure you're aware that subcutaneous immunotherapy can result in systemic reactions, including severe reactions. So probably 1 in a million injections result in a life-threatening reaction. And then overall, if you look at data going back many, many years, deaths are probably reported in about 1 in every 2.5 million injections. That I suspect the safety profile is improving over time, and if you didn't look quite so far back, the profile would be better. Nonetheless, these reactions are certainly possible. Sublingual immunotherapy, on the other hand, really hasn't given any very clear cases of anaphylaxis at all that I am aware of. Certainly not life-threatening. This study was an old study that we mentioned earlier, but actually it was reanalyzed to look at the safety of using a slightly lower dose. So rather than using the top dose of treatment, if you use 10-fold less treatment, how would the safety compare? And you can see in terms of the symptom medication score, you get a 25% rather than a 35% improvement. But in terms of severe side effects, so you go non-life-threatening side effects, there were 9 for the high dose group and none for the low dose. So it may be that in patients who are very severely allergic, you can't up dose them to maximum dose, you could rest them on a lower dose and they still get significant benefit. Side effects of sublingual immunotherapy are in a way equally problematic. They're less severe, but actually I'd say about 8%, maybe more, maybe in clinical practice, more like 10% of patients who we start on sublingual treatment for grass, birch, and house dust mite can't tolerate the treatment due to local irritation and side effects. Adherence is an issue. We obviously are careful to pick patients who we think are very well motivated to continue with the treatment for 3 years. If you look at real life studies of adherence to 3 years of immunotherapy can vary anywhere between about 18% and 90%. And obviously when you run a clinical trial, the adherence is probably going to be slightly higher because you're keeping a very, very close eye on patients. So you have to be aware that you will start patients who will not finish treatment. And the reasons for poor adherence are reported to be side effects, which makes sense, the inconvenience of having to pick up regular prescriptions, the inconvenience of having to come to a clinic, lack of efficacy, or simply just forgetting about the treatment, particularly outside the pollen season. So in summary, pollen allergy is a worldwide and growing problem with a serious impact on quality of life for a large minority of individuals. Avoiding pollen is extremely difficult, often impractical. Standard pharmacotherapy, especially the combination intranasal steroids, intranasal antihistamines, if taken regularly, is often very, very effective, even in quite severe patients. Allergen immunotherapy is generally reserved for patients failing to respond to pharmacotherapy and can be very highly effective, not in everyone, but in a large proportion of people. Side effects need to be considered. Not everyone will tolerate the treatment. Safety is important for subcutaneous immunotherapy, and simply access to treatment and the long durations of treatment are important limiting factors. All right, let me stop sharing my screen. So that's the talk. I hope it's been of interest, and if you have any questions, do let me know.
Thank you very much, Professor Scadding. That was a very clear and concise lecture. Now let us go to the third lecture for today's webinar. May we have the slide, please? So our third lecture is entitled Best Practices in the Management of Patients with Allergic Rhinitis and Comorbid Asthma. She is a consultant at the Department of Allergy, Department of Otolaryngology, Head and Neck Surgery, Beijing Tongren Hospital, Capital Medical University, and Beijing Institute of Otolaryngology in China. Colleagues, let us welcome Dr. Yuan Zhang.
Okay, thanks for Professor Racquel's introduction. And okay, good evening, everyone. I'm Zhang Yuan from China, Department of Allergy and the Beijing Tongren Hospital. And it's really my great honor to attend APAACI Masterclass and thanks for Professor Ruby Pawanka's invitation. Today, I will share with you the topic about best practices in management of patients with allergic rhinitis and comorbid asthma. Allergic rhinitis is a hypersensitivity reaction caused when inhaled allergens contact the nasal mucosa and induced Ig-mediated inflammatory resources. And AR is a global health problem, and a nationwide population-based study demonstrated that the standardized prevalence of adult AR in China was 11% in 2005 and 18% in 2011, indicating an obvious increasing prevalence. And corresponding to this, the total cost for the adult AR patients in China is 326 billion and 800 million RMB. Regarding to the increasing prevalence of AR, numerous risk factors have been described for allergic rhinitis in different stages of life, and they can be briefly divided into 3 aspects: genetic, susceptibility, pre- and postnatal events, and climate as well as environmental exposure. For example, the prevalence of pollen-induced AR in grassland in northern China was 32%, such extremely high prevalence was due to high seasonal pollen exposure, which was influenced by the local environmental and climate conditions. Actually, as early as 2009, EACI has proposed that climate changes can affect allergic airway diseases, leading to a greater likelihood of the development of allergic airway disease in sensitized subjects and aggravation in patients already symptomatic. Our previous study demonstrated that the heightened air pollution during the oak pollen season may possibly increase the incidence of allergic airway disease in sensitized individuals by facilitating the bioavailability of airborne pollen allergens. And moreover, we also find that the synergistic effect of pollen and air pollutants might also be responsible for the aggravating the symptoms of non-AR patients during the pollen season than in other seasons. As we all know, the management of AR includes allergen avoidance, pharmacotherapy, immunotherapy, and patient education. And in general, the notion that of control is a key concept in the management of all the chronic diseases. Concerning the allergen avoidance, we have established a national pollen monitoring network all over the country and release daily broadcast of pollen concentration and travel guidance during the pollen season by WeChat. And as regarding the significance of allergen avoidance, there's another level of significance. Allergic diseases often coexist in patients, and the combination of several exposure at a given time, which is named the allergen load, is related to the disease severity, and especially in children. And in this sense, a reduction of the allergen load is a key to successful treatment. AIT is currently the only curative intervention for the allergic diseases, and except for the for improving the nasal and ocular symptoms and reducing the medication need and improving quality of life, and being still effective after its cessation. And the main benefits of AIT is alter the natural cause of allergic diseases, reduce the development of asthma, and the new sensitization. And in this respect, EACI emphasizes the important role of ART in preventing allergy. Our meta-analysis of the RCTs comparing symptom score and medication score between SCIT group and the control group demonstrated that SCIT significantly reduced the nasal symptoms and medication needs in patients with AR. And our publication also confirmed that SCIT is still effective 2 years post SCIT in terms of TNSS, MS, and RQLQ. Our recent study also showed that AR patients could achieve sustained post-treatment efficiency for up to 13 years following a 3-year SCIT, and the children may gain further improvement in nasal symptoms after SCIT cessation. And regarding the candidate for the AIT, generally, AIT is recommended for the allergic disease patients with obvious allergen-related symptoms. And identification of clinical relevant allergens is the first step of patients' stratification to ensure the correct allergen agent is used for AIT. And in this respect, NAPT is helpful to confirm the clinically relevant allergens before the initiation of AIT. And considering the contraindications, I summarized that the selection of it mainly serves as three main purposes: to maximize the treatment efficiency, reduce the occurrence of adverse reaction, and efficiently implement rescue measures once the adverse reactions occurred. And there's still some special considerations. The main is that AIT should be initiated early in the course of the disease. And our previous study have proved that better improvements were observed after AIT in children compared with adults, and in AR patients with short history than long history. Of course, AIT remains underused because many reasons. Furthermore, with the advancement of medicine, health, living has made significant progress, but the success of treatment increasingly depends on whether the patient actively participates in the treatment. And during the COVID-19 pandemic, many patients have to stop their SCIT, and actually there are no evidence-based guidelines on dose adjustment for missed SCIT dose to date, and it is customary to repeat or reduce the dose when the interval between the injection is prolonged, and interruption of more than 16 weeks in the maintenance period requires that the treatment is restarted from the beginning. And in such a background, we develop a novel dose adjustment schedule for interrupted SCIT for AR. This was a prospective randomized open-label single-center clinical trial, and 68 eligible subjects were recruited from a cohort of dust mite allergic rhinitis outpatients who were receiving cluster SCIT and had discontinuous injection for more than 16 weeks. And the participants were randomized to receive either novel or conventional dose adjustment schedules. Briefly, the conventional dose adjustment schedule started from the beginning, whereas the novel dose adjustment scheduled from with 10,000 SQ dose, and rescue medication were permitted in this study. And the characteristic of this study population are shown in this table, and we can see that there were no significant difference concerning each parameters, indicating the comparability among groups. And the primary clinical efficiency of SCIT was evaluated using the daily combined symptom and the medication score between R26 and R0. Considering the comparison of clinical efficiency of novel and conventional dose schedules during the retreatment period, CSMS at the maintenance dose, as well as at our retreatment after half a year between novel and conventional schedules receiving subjects were comparable. And the similar results were obtained regarding the TSS, MS, and between groups. AIT for AR is effective, but whether delayed injection for a long time affects the overall the efficiency remains unclear. And here in our study, CSMS was significantly reduced by the end of R26 compared to baseline in both continuous and interrupted scheduled group. And the changes has no significant difference This finding suggests that the late injection may not affect the overall efficiency as long as the treatment continues. So we get to the conclusion that the novel dose adjustment schedule that used initial dose of 10,000 SQ was equally effective, and it's a safe alternative to the conventional schedule for delayed SCIT of more than 16 weeks for AR, with the advantages of saving time, cost, and reduced dropout rate. Moreover, the interrupted SCIT do not exert a significant influence on overall clinical efficiency compared with a continuous schedule. And actually, the group of uncontrolled chronic upper airway disease represent therapeutic changes, especially the adherence of the allergic allergic disease treatment is not that ideal. And the group of uncontrolled chronic upper airway disease represent a therapeutic challenge. It has been summarized as shown in this slide that different factors are related to uncontrolled airway, upper airway disease. And in this sense, novel treatment or treatment strategies are needed to improve adherence and management of patients whose symptoms are inadequate controlled with standard medication care. And the application of biologically targeted drugs is an important direction for addressing uncontrolled allergic disease, especially for example, for asthma and allergic rhinitis. And omalizumab is a good example. And this slide demonstrates that the meta-analysis of RCT studies regarding the clinical efficiency of omalizumab in allergic rhinitis. And meanwhile, there is no statistically significant difference in adverse events. Whereas to date, no study have evaluated the efficiency of pre-seasonal omalizumab therapy with cost-effective dose and at appropriate time point compared with standard therapy in SAR patients. And thus, we carried out a study to compare the efficiency of a single dose of omalizumab treatment with standard medication administered about 2 weeks prior to the pollen period in controlling symptoms and medication use during the autumn-fall season in Chinese patients with SAR. And this is a prospective randomized controlled open-label single central clinical trial. And there are 4 visits in present study. Visit 1 is for the screen. Visit 2 is for single 300 milligram subcutaneous injection of omalizumab about 2 weeks before the start of autumn pollen period. And allergen symptom relieving medication were permitted according to the actual needs in both groups. The primary efficiency endpoint was the mean change from the baseline of daily combined symptom and medication score for the nose. Here we define different pollen phrase according to the total daily pollen account. Let's look at the result. We can see that omalizumab pre-treatment for the current autumn pollen season significantly decreased the changes of the mean daily CSMS of nose and eye scores during the entire pollen period compared with the standard medication. And the data also showed that omalizumab pre-treatment significantly decreased the changes of average daily MS during the whole pollen season compared with the medication therapy group. In addition, the portion of the allergen symptom relieving medication 3 days during PPPPP was significantly higher in Armalite-mab pretreatment group than in the standard medication treatment group. And then finally, we further compare the patient global impression of change between the two groups, and we found that patients in the Armalite-mab trip were more satisfied with the control of AR symptoms, whether between the group compared with the medication treatment group, or within the group compared with their own status in last autumn. Then we concluded that administration of a single injection of 3 milligram Armalite-mab 2 weeks before start of the pollen season achieved better overall control of symptom and quality of life, with significantly reduced allergen symptom relieving medication usage compared with standard pharmacotherapy in SAR patients. For another issue, so far there's a limited direct clinical evidence informing the treatment of airborne pollution-related rhinitis. We recently carried out a phase 4 randomized double-blinded placebo-controlled multi-center study to assess the effectiveness of the budesonide in adults in self-reported rhinitis symptoms triggered or worsened by airborne pollution. The primary endpoint is the mean changes from baseline in 24 hours reflective total symptom score averaged over 10 days. And the final efficiency results show that the 10-day average rTNS change in the budesonide group was greater than with placebo, provide first the direct evidence on the efficiency of intranasal corticosteroid for the rhinitis symptoms relief during the high airborne pollution. And so, in summary, firstly, the population of allergic rhinitis is a huge, and social economic burden cannot be ignored. And the environmental issue has a significant impact on the upper airway, allergic diseases. And the management of AR includes allergen avoidance, pharmacotherapy, AIT, and patient education. We should emphasize the allergen testing and guide the prevention and treatment of allergic diseases, and understanding the significance of AIT in the treatment and the prevention of comorbidities in allergic diseases such as asthma, especially in the pediatric patients. And finally, the bio-targeted agents are a new direction for allergic disease treatment, but health economics and long-term safety need to be considered. Actually, in the field of allergy, Chinese scholars have committed vast resources and time to understand it. And for example, we published Chinese guidelines for AR diagnosis and treatment and AIT. We have also published China issue in Journal of Allergy 3 times. I have also invited twice to publish a review on the new progress of AR in the Journal of Allergy. I hope we have more opportunities to collaborate with colleagues, especially in Asia, in the future, and contribute to the field of allergy. Okay, thank you for your listening.
Thank you very much, Dr. Zhang. That was a very comprehensive lecture. Now we will go to the open forum. May I invite all the speakers to open their video. Unfortunately, Professor Guy Scadding cannot join us for the open forum because he's still attending to a patient right now. So from the Q&A box, we have a question for Professor Smith. First question is, what is the adrenaline dose? We used to give it IV. We used to give adrenaline through IV, diluted, 1 ampule, added to 10 cc of normal saline. And we give 1 cc, monitor the patient every 5 minutes. And if there's no response, we give another 1 cc. What can you comment about this, Professor Smith?
There is a lot more safety in giving it intramuscularly. In a hospital situation where somebody is monitored, yes, and in critical situations in this failures of intramuscular or the patient is unresponsive, you may choose to give it intravenously, but that is critically life-saving and there are risks of giving that intravenously. The dose is 0.01 milligrams per kilogram. So normally for about a 15 kilogram child, well, somebody usually we're thinking about 10 to 20 kilograms, we'll use the 150 microgram or 0.15 milligram dose. And for somebody 20 kilograms above, we use a 300. And now they're actually for the over 30 kilograms, even 500 microgram auto-inject depends. If you're drawing it up and you've got a child, 0.01 milligrams per kilogram. So you might get a 0.1 of a mil of the 1 in 1,000 intramuscularly. If there's a, so 10 kilograms, 0.1 mil, 20 kilograms, 0.2 mils. 50 kilograms, you might give 0.3 to 0.5 milligrams. If you're doing it intravenously, you're using a 1 in 10,000 dilution, not the 1 in 1,000 dilution. But that is for people who are very experienced, not for the average person. You are far safer to give it intramuscularly. And as I've mentioned before, in the mid-lateral thigh, the sweet spot is about 13 millimeters where there is maximal absorption. This goes in by lymphatics, endomyosium. In the endomyosium, there's lymphatics and that veins. It's quite rich in that area. It seems to have fallen off many of the management plans, but I still like to give the area a bit of a rub to get it in. And we can see that when patients are actually attached to the an ECG monitor just by giving a rub, we all of a sudden, bang, their heart rate increases and there's a response from that.
Yes, and I believe in the yes.
There was a comment about giving if it's not working, giving it all. Giving one more than a milligram does have a risk of Takotsubo myopathy, where you may get too much inotropy and chronotropy occurring in the heart, and you may get the cray pot, Japanese octopus phenomenon, where you may get ventricular dysfunction and may get poor output from too much adrenaline. So if you're given more than a milligram, somebody's got poor output, have a look at their heart as well. So I'm very cautious about giving intravenous pushes. I'm also very aware that the auto-injector devices are very expensive and they may not be available in all countries. So having it drawn up of a 1 in 1,000 vial, it's hard to give more than a vial. Giving a little part of the vial is easy to work out.
Thank you. And I believe in the anaphylaxis guidelines, it says there that the intramuscular route is better and it works faster for emergency cases of anaphylaxis.
Getting IV access in an emergency situation is can muck around 5 minutes. You wanted early adrenaline, it's good. Intramuscular is the easiest and fastest and safest mechanism.
That is correct. There is a question here. It is addressed to Professor Scadding, but I think Professor Zhang can also answer this. I wonder, during the COVID restrictions, did wearing a mask help to reduce pollen exposure significantly and help reduce symptoms? For Dr. Zhang.
Okay, I suppose maybe the mask is a benefit for the pollen exposure for the patients allergic to the pollen, and according to our observation during the COVID-19, all the patients with SAR, they has not that severe symptoms of nasal and ocular symptoms during this period. So I think it is a benefit for them. Yeah.
Yes, and most of us stayed indoors. That's why pollen allergy were not so much during the pandemic, right? There's another question for Professor Smith, but I believe you already typed your answer, but for the benefit of the audience, can you answer it again live? The question goes, how do you perform allergy desensitization to bee and wasp anaphylaxis? Do you do it sublingual, subcutaneous, for how long? And for how long?
The recommendations from the American Academy, the European Academy, ASCIA, World Allergy Organization is for 5 years for a bee or wasp or ant desensitization. We identify how sensitive the patients are by doing serial dilutions down to 0.1 micrograms per litre, and we then will work out how sensitive they are at those two lowest doses and initiate the dose of that, usually about a 14 to 15 weekly build-up, and then we end up giving them about 1 ml of the 100 micrograms, actually 100 micrograms per ml dose. And that is done for a period of 5 years. What it does, it brings down their risk of anaphylaxis generally 70 to 80% with subsequent stings, and they still have their auto-injectors for life. There's about a 3-fold improvement in quality of life scores because these patients are feeling a sitting duck for waiting for their next sting. By having the immunotherapy, not only do we reduce their risk, but they feel like they're actually being proactive to that. So there's actually this psychological benefit as well. So it's it helps in several ways.
Okay, thank you, Professor Smith. For Dr. Zhang, do you recommend switching from switching form of immunotherapy, like from skip to split and the other way around?
I beg your pardon?
Do you recommend switching form of immunotherapy, like from subcutaneous to sublingual or from sublingual to subcutaneous? Do you recommend such form?
Okay, I suppose which is better, it's just depend on the patient's choice. Because for some patients, they do not want to go to the hospital more times. They can use the LIT at home, and if they want to, if they think it's better for them to go to the hospital, they can choose the CIT. And according to our observation, we don't think there's very different. Very significantly difference between these two routines about the efficiency. Yeah.
Okay, thank you, Dr. Zhang. For Professor Smith, there's a comment here. I find most doctors hesitate giving adrenaline when they suspect anaphylaxis. I recommend, when unsure, safer to give than not to give, as it's safe and life-saving. What are your thoughts on this?
Once you've given it, you'll never go back. You know, it's an initial, we think of it as a dangerous drug. It is dangerous not to give it. And that's hence the statement, if in doubt, give it. And we see that with the patients. Once they've given it, they feel so much safer. And, you know, if you're under 15 kilograms, you know, you're looking at 0.15 mils over the 1 in 1,000 if you're drawing it up yourself. And I'd go in half the length of a 1-inch, a 25 mil needle if you're injecting it into the lateral thigh. If you're drawing it up and giving it, it can be very stressful breaking this a vial and drawing it up. Auto injectors have become more available. I can remember 15 years ago doing the launch of a particular auto injector in Thailand. Actually, it was about 17 years ago, and that was the second country in Southeast Asia to have an auto-injector pen. So that's certainly more prevalent now.
Okay, thank you. For Dr. Zhang, what is your worst side effect experience in immunotherapy and how did you manage it?
Actually, because I'm an ENT and the majority of patients are receiving immunotherapy is allergic rhinitis, and only very little portion of patients have asthma. And so in our clinical center, I actually the side effects of the immunotherapy is very rare. And so if I think if the immunotherapy is very suitable for allergic rhinitis, and we think it's a very safe treatment approach. Yes, thank you.
Okay, how about you, Professor Smith? What's the worst side effect have you experienced with immunotherapy?
Anaphylaxis. And in contrary to Guy's comment, yes, we've had one sublingual anaphylaxis as well, which is reported, and at the time it was the 13th that had been reported in the world. So there are cases. This patient was had eaten their breakfast. We actually asked them not to eat before they had their sublingual. This person had scratched the mouth. So essentially you had a raw open sensation. This patient had a history of nut allergy. They hadn't eaten anything with nuts in it. They'd had some crunchy cornflakes, scratched their mouth, gave their immunotherapy, had airway swelling. Both parents were doctors and recognised airway compromise and tongue swelling, lip swelling, and they'd essentially received a massive dose of their sublingual immunotherapy. With the aqueous forms that we used to use, the anaphylaxis rate was 1 in 500, 1 in 1,000. With the alum forms that came in the mid thousands to more recently, the risks, and they're still available now, about 1 in 7,000 or 1 in 14,000 shots will cause anaphylaxis. The polymerized forms, the allogoids, really low rates. You know, we're looking at people having more than 100,000 doses and not seeing anaphylaxis. But yes, we make sure they've got good lung function at the time. We make sure we do baseline lung function as well. And now patients are getting on biologics, which gives us a safer level, a safer platform to which to do these immunotherapies as well. And it's a way out of needing the biologicals if you're having biologics for allergic asthma to actually do this. So it's a real opportunity to grab these patients and do immunotherapy. The comment about one over the other, there is a little bit more allergen-specific IgA production with sublingual, a little bit more allergen-specific IgG4 with SCIT. So sometimes I'll add, somebody's failing their SCIT, I'll add a little bit of sublingual, purely anecdotal, purely and on a molecular basis, but I might give them a few months to give them a bit of a boost.
Yes, I agree. Anaphylaxis is the worst side effect of immunotherapy. That's why epinephrine should always be ready in our clinic, right?
Yep, agreed.
Another question for Dr. Zhang. How do you determine if to stop at 3 years or continue till 5 years of allergy immunotherapy? If given 3 years and relapse does occur, do you give it for another 3 years?
I suppose that the duration of the whole immunotherapy time is at least 3 years, and if the patients want to continue to the immunotherapy, I suppose I will encourage them to do that, because according to our observation, the patients has the very good efficiency after 3 years immunotherapy, and the long efficiency can sustained about 13 years. And I suppose maybe the patients just receiving more than 3 years immunotherapy, there will be a more long efficiency time in the future. But if we want to get the very exact result of this question, we must get a very long observation of this issue. Thank you.
Okay. Another question for Professor Smith. how does intranasal adrenaline compare with intramuscular adrenaline?
Very good. Somebody's been reading the FDA recommendations. There's a new drug that has been approved by FDA to actually have similar efficacy. My concerns are that these studies have been done on healthy controls, not patients with active rhinitis. So, so we will see, and we'll get that data more in the next sort of 12 to 24 months. But yes, there is intranasal forms available that are just going to be hitting the markets in the US. I personally have no experience with them, but to have FDA approval, they must show non-inferiority is usually the goal, rather than gain of superiority. If there was superiority, we'll be hearing it from the rooftops.
Okay, thank you very much, Professor Smith. We need, due to time constraints, we need to end this Q&A portion. For the questions of Professor Scadding, he will answer the question when this session is posted in our website. So thank you very much. This has been a very fruitful day. We learned a lot in the management of difficult to treat allergies. Our gratitude goes to our three esteemed speakers, Professor Smith, Professor Scadding, and Professor Zhang. You all gave excellent lectures, and you all deserve a big round of applause. Thank you very much. On behalf of the officers and organizers of the APAACI Masterclass, thank you everyone for attending and for participating in today's webinar. So we would like to invite everyone this coming October 23 to 26 for the upcoming APAACI 2023 International Conference entitled The Innovation Revolution, Allergy, Asthma, and Immunology. And this will be in Singapore. The scientific program is full of interesting topics on allergy, asthma, and immunology. And you're also invited to submit your research abstract now at the APAACI website. So thank you very much again for joining us. We now end this webinar. May I invite the speakers for a photo op. Professor Ruby, are you here?
They're doing a screen capture, are they?
Sandra,
taking the
will you be
photo,
the one
thank
to do the photo?
Hi, Ruby.
Hi,
Ruby.
I just reached home. I
Professor.
was listening to everything on the phone. It was really excellent. Very good.
How are
I mean, it was
you?
brilliant
How
session.
are you now?
Right.
Oh, well,
We have excellent
recovering,
speakers.
recovering.
Let's
So it
smile
was
for
excellent.
let's smile for the photo op. 1, 2, 3. Okay. Thank you
Thank
very
you so
much.
much. Thank you for the
Take care,
wonderful
Professor.
moderation, and thanks for the lovely talks. They were just brilliant.
Pleasure. Thanks very much.
Thank you,
Pleasure.
thank you.
Okay.
Our
And
pleasure.
okay, thank you for inviting everyone to the Congress. We please let's encourage as many abstracts and registrations to the Congress. The program is really coming out well. Okay, thank you so much, Pete. Lovely. It was really
Pleasure.
wonderful. Thank you, Dr.
Might
Zhang.
see you in
Yeah, thank you,
November.
G.
Okay,
Thank
bye.
you. See you.
Bye.
Bye.
See you.